Okay, so this is a constantly changing field. It's really quite exciting because there's a paper out almost every day. Just to declare my conflicts of interest, I don't take money from Big Pharma, and I sit on the NICE COVID-19 Guideline Development Group. We had a meeting yesterday to discuss thromboprophylaxis, actually. I'm also on the WHO COVID-19 Guideline Development Group and also on the post-COVID group that they have, and also we're looking at multi-system inflammatory disorder in children, another one. And I advise the Royal College of Obstetricians on COVID, and I am involved in some of the trials I'm going to talk you through. I think we all know about COVID. It enters the body through the ACE2 receptor in the nose and pulmonary epithelium and endothelium. And thankfully, most people have asymptomatic or mild infections. Interesting, actually, that the Delta virus tends to cause more cold-like symptoms than flu-like symptoms, much more of a head cold. And of course, we have loss of taste and smell, with most people getting taste and smell back, but about 10% left with persistent problem. And the problem for us in hospital is that we are getting those who go on after 7 to 10 days to get COVID pneumonia. And we know that we divide those patients up according to the WHO criteria of moderate. So they're on the ward and they need supplementary oxygen. And then we have severe critical, where they need mechanical ventilation. And the hallmark of COVID pneumonia is that within the lungs, there's an incredible inflammatory response. The histopathology shows invasion of macrophages, lymphocytes, huge cytokine production. And part of the cytokine production is interleukin-1 and interleukin-6, which are responsible for the acute phase response. And this will induce a prothrombotic state. And interestingly, those who are at high risk of COVID pneumonia all have a pre-existing inflammatory state. So you become more inflammatory as you age. Atherosclerosis, diabetes, and obesity are all associated with this problem. If we look at the patients in critical care, this is the first 66 we saw at Guy's and St Thomas's, and we have a look at their prothrombotic state. We have really high levels of fibrinogen, so that's the top left. And we've separated these patients out to those that we thought had VTE and to those who didn't. And you can see that the levels of fibrinogen stretch up to about 11. Somebody needs to mute there. And since this time, we've seen values of fibrinogen up to 14, which is incredible. So the mean value is about 6 or 7, the type of value you see at the end of pregnancy in a healthy woman preparing for delivery. And then the other hallmark is these incredibly high levels of D-dimer. So this is a logarithmic scale, so super increased levels of D-dimer. Not that much difference between those with VTA and those without. And at the bottom, we've got procalcitonin, ferritin, and CRP, all very elevated. And when you follow a patient, the ferritin and the fibrinogen and D-dimer all tend to go up and down together. So at the start of the pandemic, way back last year, last April, the critical care physicians were seeing a lot of thrombosis, and they did a lot of CTPAs when they were allowed to. And what came out of the studies was that it appeared that patients had enormously high levels of venous thromboembolism because they had a lot of positive CTPAs. And so we have some records. There's a French one where that 79% of the patients are said to have VTE. Now, we also know that if you have acute respiratory distress syndrome, you will get fibrin deposition in the lungs and also microvascular thrombosis. That is the end point of inflammation. So the more inflammation you've got, you will get microvascular thrombosis in the inflammation, and that will show up on a CTPA as a segmental or subsegmental change. So you could argue that when they looked at the CTPAs, they were measuring this immunothrombosis, part of ARDS, and also pulmonary emboli. And so the bottom study on this slide, the Desborough one, that's our team at Guy's and St Thomas's, put down a rate of VTE of 5%, and that they all had thromboprophylaxis, and that feels much more real. And what we have done is removed the scans where they just had segmental and subsegmental changes. So we have this issue with COVID-19 that we're picking out this long forgotten thing with ARDS. You will get small vessel involvement. And then, of course, the perfect recipe for VTE is COVID. We're immobilizing the patients. The endothelium is activated. COVID is entering the endothelium for the ACE2 receptor. So we've got endothelial cell activation and this fantastic prothrombotic state. So it just brings us back to the fact that actually coagulation evolved as the end point of the inflammatory state. And if you were a primitive organism and you had bacteria invading, you'd want to wall them off. And that's what we're doing. We're walling them off with fibrin deposition. And myself, coming from a background, I'm a bit of an oddball. I'm also trained in rheumatology as well as hematology, and I used to run all the vasculitic clinics and Behçet's clinics, and we always were seeing microvascular thrombosis, and we knew they had so much inflammation, we needed to treat them with anti-inflammatories. All the new biologicals have revolutionized the treatment of vasculitis and Behçet's. We would give them anticoagulation, but we wouldn't expect the anticoagulation to stop these events. And then what have we done with COVID-19? We have very hypoxic patients. After all, that's why we're admitting them. And hypoxia induces a really prothrombotic state by inducing hypoxia-inducible transcription factors, which will bind to the promoter areas of some of the coagulation genes, such as tissue factor, and the PI1 gene, which switches off fibrinolysis. There are now many papers on mechanisms of the coagulopathy in COVID-19, and whatever you read, it's switched on. So we know there's huge activation of mitosis, so the neutrophils expel their histones and their DNA, which would activate tissue factor. Platelets are activated. The neutrophil count is high and correlates with severity of disease. I think the D-dimers are really interesting. So they got everybody, I think, at the beginning of the pandemic, and everyone took it to mean, because we used D-dimer as a negative predictive factor for having a PE, that this meant there was high rates of thrombosis, and these patients were more at risk of thrombosis than others. If we look at this paper from Wuhan, then we can see that comparing COVID patients who are ventilated with the previous year's non-COVID patients with acute respiratory distress syndrome shows that at the bottom, they both had really high levels of D-dimers. So D-dimers are actually another marker of acute respiratory distress syndrome. And if we think about that, so just to remind you that D-dimer is a breakdown product of fibrin in the blood. We are talking about TPA, tissue plasminogen activator, activating plasmin and breaking down fibrin. And we always think about this because one of the stimulators of TPA is thrombin. So when you make a clot, you switch on clot breakdown, which is why you get high D dimers in patients who are clotting. But we have the lungs to consider. And so we've got this issue, we've got intravascular fibrin deposition, and we know that we need to remove that. And did you know the pneumocytes can actually produce the equivalent of TPA, which is called urokinase in the tissues, and that will break down the fibrin and release the D dimers, which will overflow into the plasma. And we know from a mouse model of SARS that the worse your lungs are, the more urokinase you will produce. So is it surprising that D dimers are a marker of outcome in COVID pneumonia? Because they're actually saying there is a lot more urokinase being produced because there is far worse pneumonia. And the other cell that is really important for fibrinolysis are the macrophages in the lungs. So they can generate plasmin and break down local fibrin, and they can also grab passing fibrin, pull them in to their little granules where they gobble it up and break it down with cathepsin D, a totally independent pathway of fibrinolysis, and spit it out again into the blood. So the issue for me, and it's just astonishing really to see COVID, because I've had a long career and have never seen such a prothrombotic group of patients. Is COVID-19 the most prothrombotic state that we have seen in critical care or anywhere? And so this paper partially answers it. So we looked back at the patients that we have been putting on ECMO. Before we put them on ECMO, we do CTPA, and we've been doing this for years. And we've been putting many people on ECMO for a long time. And we look back at those mainly with H1N1, a lot of pregnant ladies who we'd put on ECMO. And we looked at all of the X-rays again. And you can see that when we look at the number of filling defects, this is the first row, there were definitely more in those with COVID-19. So they've got the same roughly degree of hypoxia, but evidence of more thrombosis. When we look at the segmental and subsegmental changes, or what we were calling pulmonary immunothrombosis, again, 4% in those with other influenzas, 40 or 27% in those with COVID. And then again, we get high rates of intracranial hemorrhage, but no more with COVID. And lastly, when they come off ECMO, we do a Doppler ultrasound to look for DVT, because we're putting big cannula in the large veins, and again, higher rates of DVT. So to me, this suggests we're getting more thrombosis with COVID pneumonia than any other viral pneumonia. So what have we been doing with thromboprophylaxis? Well, we had very little evidence to start with. In the UK, we thankfully VT risk assess everybody, and we give thromboprophylaxis. And if you're in critical care, the practice is to give thromboprophylaxis to everyone unless they've got a bleeding problem. We're talking pharmacological thromboprophylaxis. This is not true for the rest of the world. So this is data, really early data from one of the Chinese hospitals, and we've got patients with severe COVID. 22% received heparin. We don't know what dose. We don't know why they were given heparin. So clearly they don't get it routinely. Presumably they had VTE, but they had a lower mortality. And so that was taking us forward. Now, the critical care physicians, many of them upped the dose of thromboprophylaxis they used because of the perception of these very high rates of thrombosis and also the prothrombotic state. And it was only when we got to Christmas that we had the early results from the REMAP-CAP trial, and that is hopefully going to be published. It's been accepted for publication and it's just sitting, waiting to be published. So REMAP-CAP was looking at the difference in outcome between thromboprophylactic low molecular weight heparin and full therapeutic dose anticoagulation. And we have two arms of REMAP-CAP. So REMAP-CAP traditionally is looking just at critically ill patients. So this is the results from the critically ill patients. And the primary outcome was, and using Bayesian statistics with an ordinal scale, we won't go there because that would take 20 minutes. They looked at organ support free days and survival. And just if you look at that graph, you can see that therapeutic anticoagulation does not produce increased survival. And what it did do, however, was cause major bleeding. So we had major bleeding in 3.1% of those with therapeutic anticoagulation and 2.4% with usual thromboprophylaxis. The usual thromboprophylaxis is standard or intermediate dose. So this is saying no benefit of full heparinization in critically ill patients. Now, traditionally, Recovery has done all the trials in the ward patients. They were not interested in thromboprophylaxis. We did go to them. So REMAP-CAP had a moderate arm. And they combined their data with a couple of American RCTs doing exactly the same thing. That's ATTACK and ACTIV-4. And we have got 2,200 patients. And the trial was stopped in December because there was a clear outcome. And in the moderate patients, therapeutic anticoagulation is amazing. It seems to improve organ support free days compared to standard thromboprophylaxis. And we have increased major bleeding, but it was 1.9% compared with 0.9% with standard of care thromboprophylaxis. This came from the preprint. The final paper says just the same. So this is really interesting. And if we think about modern care, we are giving dexamethasone to the moderate patients now, and we're giving heparin as well. If you look at I can't show you all the data, but there is only a slight reduction in VTE. And it looks like heparin, which also has anti-inflammatory properties and also potential antiviral properties, is probably not working to reducing VTE, but has an additional anti-inflammatory effect. And you could argue that those who've gone to critical care, and I'm quite happy to be shot down shortly when we have this discussion, have passed the phase when they would benefit from an anti-inflammatory drug. So we have got this other paper, which was done mainly in Iran, comparing intermediate dose enoxaparin with standard dose enoxaparin, 600 patients. It's called the Inspiration randomized trial, and it shows very little benefit, no statistical benefit in using intermediate dose enoxaparin in mainly critically ill patients. And then we have the ACTION trial. So this is a Brazilian trial, and this is where they looked at full dose anticoagulation again versus standard of care. And in this one, they mainly use rivaroxaban 20 for 30 days rather than low molecular weight heparin. Now, in this trial, there was no benefit with therapeutic anticoagulation, but we are using rivaroxaban, which doesn't have anti-inflammatory or antiviral properties. And the other issue was there was a significantly increased rate of major bleeding. So the take-home message from this is do not use rivaroxaban as thromboprophylaxis in the COVID patients. We also have now got data coming through about the antiplatelet agents. So Recovery randomized over 7,000 patients to aspirin versus no aspirin. And there was no evidence that aspirin reduced mortality. And we also know that REMAP-CAP has just closed an arm where they compared no antiplatelet with a PY2 inhibitor, so usually clopidogrel or aspirin, and they have closed that. That's in the critically ill patients because there's no evidence of benefit. And again, we've got this issue is actually if you give an antiplatelet agent, you're going to increase the major bleeding rate too. So now we need to look at extended thromboprophylaxis post-discharge. So what evidence do we have? Well, we have a dearth of evidence. We've got scraps here, there, and everywhere. So we've got the best UK data from King's College, and this is a retrospective study. They don't use thromboprophylaxis post-discharge, and they looked at the rates of post-discharge venous thromboembolism up to 6 weeks in their patients after COVID and compared them with the medically ill patients, an equivalent group, in the year before. And they found that there was a slight increase in the rates of VTE compared with the medical patients, but it still was a very low rate. On the right, we have got data from GSTT and Addenbrooke's. Both of these places use thromboprophylaxis, and we've hardly seen any events. So not enough data here to tell us what to do, but suggesting there is a very low rate of VTE post-discharge. I think the biggest data comes from this, they say it's prospective registry from the Northwell group of hospitals in New York. And this looked back from March last year to May last year. They had more than 8,000 patients discharged. They had 11,000 admitted, so they lost about 30%, which is very similar to our figures. And they called them all up on the telephone day 90 and also gathered their coding data so they could find out if anybody had had a VTE. Now, they gave thromboprophylaxis post-discharge if their patients appeared to be high risk by a scoring system called the IMPROVE score. It's a very simple one. If you have critical care admission or you've got some risk factors, particularly if your level of D-dimer is twice the background rate, you would get thromboprophylaxis. I haven't bored you with showing you all the data from the study, but their populations are very similar to ours. The COVID admissions have high rates of comorbidity, hypertension, cardiovascular disease, diabetes, more men than women, high rates of obesity. 18% had a BMI over 35. So we can see here for what they gave them. And the other important thing to remember is we are the best in the world at thromboprophylaxis. We are talking about 8,000 patients, and many of them did not get, this is a breakdown of 4,000 patients, did not get thromboprophylaxis at all. We also have got evidence of the US partiality for unfractionated heparin. We know from studies now that low molecular weight heparin gives you better thromboprophylaxis than unfractionated heparin. And then we've got a mix of other things thrown in. So their post-discharge VTE rate, so that's from discharge to day 90, which is our part of our definition of hospital-associated VTE, which is during admission and up to day 90, was 1.55%. In the 13% that got anticoagulation, they reduced the VTE rate by about 50%. And that's what really we're doing in hospital. We would expect low molecular weight heparin to reduce rates by about 50%. But the question is, if you've got quite a low VTE rate in the first place, is it actually cost effective and is it justified? So the evidence is out for the moment about extended thromboprophylaxis. So this is the current NICE guidance. Now, when this was produced on COVID, we didn't know what to say about post-discharge thromboprophylaxis. We were aware that probably about half the hospitals are using it. So we just wrote down, essentially, think about it, consider it for high-risk patients, but there's no clarity that there's any benefits in these groups. And locally at Guy's and St Thomas's, we do much the same. We give patients thromboprophylaxis if they appear to have risk factors. So if they're aged over 75, they've had a critical care admission, or the D-dimer more than twice the normal. So everything I said has been written in a BMJ editorial, which is freely downloadable and condenses all the information. And I'm coming to the end. I would love to talk to you about FITS, but I haven't got time. I just think COVID-19 has been the most extraordinary period in time for the thrombosis community. We have seen the most prothrombotic state we've ever seen with viral infections. The UK has been right at the front using thromboprophylaxis. There is now evidence that full anticoagulation early during inpatient stay for the moderate improves clinical outcome. What I haven't talked to you about is the increased rates of VT we've seen outside of COVID, lockdown, increases in immobility. So many people have got a COVID tire. And so many people have been sitting around at home, not leaving the house. We've now also got vaccine-induced thrombocytopenia and thrombosis. And at the moment, starting to look at the post-COVID-19 syndrome, long-COVID, to see whether that has any relationship to increased thrombotic risk. So thank you for listening. I think we need to talk about extended thromboprophylaxis. Thank you.
Brilliant. Thank you, Beverley. I guess I'll start, I think, with probably the most common question we get asked as part of the Heal COVID team is, should we be routinely using extended prophylaxis when we're sending patients home, or should we be doing things like randomised to Heal COVID?
So we definitely need an RCT. We definitely do, because the data we have is retrospective, or it's from a prospective registry. So the current evidence says the rate is very low. And, you know, if you've got a really low rate, you've got possible harm if you give thromboprophylaxis, haven't you? Because it's not without bleeding risk. So we really do need a randomized controlled trial, and hopefully you will come up with the answer as to whether or not thromboprophylaxis is helpful post-discharge.
Do you think the current NICE guidelines preclude people from randomising? Often people are worried that the guidelines say you must give the treatment in particular groups of people, and that randomising to a trial where you might not get anything is not okay.
They don't. So with NICE, they use set words, don't they? So they say offer if you have to do it, or consider if they have got no idea at all, and so to consider. And I mean, I think the other thing about us as a community is the UK has got very used to thromboprophylaxis. They're very happy to prescribe it and got not afraid of it, whereas in many other countries they're afraid of using anticoagulation in any form because they only see bleeding problems. So I think we actually need to hold back a bit more from prescribing unless somebody really has a major indication.
Brilliant. So we've got some